Measuring cardiac output is a cornerstone of hemodynamic monitoring, moving historically from highly invasive gold standards to modern non-invasive digital approximations. The primary clinical modalities are categorized by their level of invasiveness, mechanism, and mathematical principles. Among the invasive methods, that is the traditional standards, the direct Fick principle is based on the law of conservation of mass. It assumes that the rate of oxygen consumption VO2 by the body is equal to the amount of oxygen taken up by the lungs. The formula cardiac output is equal to VO2 divided by the difference between arterial and venous oxygen content. CaO2 is arterial oxygen content and CvO2 is mixed venous oxygen content sampled from a pulmonary artery. While considered a gold standard, true direct Fick requires a metabolic hood to measure actual VO2. In most cath labs, indirect Fick is used, substituting assumed metabolic rates based on age and sex, which introduces error in hypermetabolic or critically ill patients. Indicator dilution and thermodilution. A known quantity of an indicator, originally it was green dye, indocyanine green, now it's called saline, is injected into the right atrium via a pulmonary artery catheter. A thermistor at the distal tip measures the temperature drop in the pulmonary artery over time. The formula, Stewart-Hamilton equation, it's a very complex formula where V is the injected volume, Tb and Ti are blood and injectate temperatures, K1 and K2 are correction factors, and the denominator is the area under the thermodilution curve. While it is highly accurate, it is prone for errors in the presence of severe tricuspid regurgitation, intracardiac shunts, or rapid fluid infusions during measurement. Moving on to minimally invasive methods. Pulse contour analysis. These systems utilize algorithms to analyze the arterial pressure waveform morphology obtained from an arterial line. The area under the systolic portion of the curve is proportional to the stroke volume. Uncalibrated methods use demographic data and waveform characteristics to estimate vascular compliance CT and resistance. In calibrated methods, they require an initial transpulmonary thermodilution or lithium dilution injection to calibrate the vascular compliance factor, offering higher accuracy in unstable shock states. Highly sensitive to arterial line damping, whip, and acute changes in vascular tone, like sudden vasopressor initiation. Esophageal Doppler. A flexible probe is placed in the mid-esophagus to measure blood flow velocity in the descending aorta using the Doppler shift. Stroke volume is calculated by multiplying the velocity time integral by the cross-sectional area of the aorta derived from nomograms. It provides excellent real-time B2B trends but is highly operator dependent and limited to sedated or intubated patients. Non-invasive methods. Echocardiography using Doppler ultrasound, the clinical workhorse for non-invasive cardiac output measurement. It measures the velocity of blood flow through the left ventricular outflow tract during systole. The formula is stroke volume is equal to VTA of LVOT into cross-sectional area of LVOT. VTA of LVOT into pi into diameter of LVOT divided by 2 whole squared, that will be equivalent. Cardiac output is stroke volume into heart rate. D is the LVOT diameter measured in the parasternal long axis view, and VTA is traced from the pulse wave Doppler in apical 5-chamber view. Because the LVOT diameter is squared in the geometric equation, even a 1 mm error in diameter measurement can significantly alter the calculated cardiac output. Bioimpedance and bioreactance. Thoracic electrical bioimpedance measures changes in electrical resistance across the thorax during the cardiac cycle. As blood, which is a highly conductive liquid, is ejected into the aorta, resistance decreases. Bioreactance, an evolution of bioimpedance that measures the phase shift of high-frequency electrical currents as they pass through the thorax. It is less susceptible to motion artifact and patient positioning than older bioimpedance systems. Cardiovascular magnetic resonance utilizes phase contrast MRI to measure velocity and flow directly within the descending aorta or main pulmonary artery. It is exceptionally accurate and independent of geometric assumptions, making it the non-invasive gold standard, though limited by cost, availability, and lack of real-time bedside utility.